Hello, and a very warm welcome to today's ISNTD Connect. I'm Marianne Compered, and I'm speaking from the International Society for Neglected Tropical Diseases, and it's really my pleasure to welcome you here today for this very exciting session with lots of insights and lessons from case detection in remote or challenging environments. The last few years have seen many successes in the reduction of neglected tropical diseases in many parts of the world, with some countries achieving elimination in one or even in some cases several of these age-old diseases. And so against this backdrop of very positive news in numerous regions, with some disease burden coming down in some areas quite substantially, it's never been as important as now to really keep a very close eye on the cases that do remain, and whether that is to ensure those regions remain on track for elimination or working towards the goals, or just to keep an eye on monitoring the appearance of any new hotspots or persistent ones. And from this local scale, this also feeds into those all-important disease surveillance systems, whether to support programmatic efforts, adequate responses, but also quite simply to get a better understanding of the global disease burden. And as most of you, I'm sure, on this call know, that is a lot easier said than done. And therefore, that's why it's my real pleasure today to welcome our three wonderful speakers who will be sharing firsthand in-field experience about what are the challenges and the strategies that they've encountered for finding those cases of sometimes forgotten or completely unknown diseases. So I'm sure you will all join me in welcoming very warmly our three speakers today. First, we'll hear from Dr. Belen Dofitas. Hello, Belen, and welcome to our call. Belen, you're joining us from the Department of Dermatology at the University of the Philippines Manila and the Philippine General Hospital, and you will be speaking to us about how to find a forgotten disease like yours, and your lessons from the Philippine experience. Thank you for being here.
Thank you, Marianne.
Thank you. We're also joined by Dr. Tine Huyse. Tine, you're with the Royal Museum for Central Africa in Belgium, and you're also representing the ATRAP Project today. Welcome.
Thank you, Marianne. Nice to be here.
Thank you, Tine. We're very excited about your really innovative, creative approaches using a lot of community engagement to track and map snails and schistosomiasis. So thank you for being here. We also have Dr. Adeniyi Semiyu Adetunji. Dr. Adetunji is a surgeon and works a lot with the Noma Children's Hospital in Sokoto, Nigeria, northwest Nigeria. And Dr. Adeniyi will be talking to us about the search for Noma cases in the community. So I see the connection has dropped, but I have complete confidence that Dr. Adeniyi will be back with us just in time for the presentation. So without any further delay, it's my pleasure to hand over to our speakers and to hear a lot more about your efforts and also your advice, your lessons learned from yaws, schistosomiasis, and Noma. Dr. Belen, over to you. I'll start your slides.
I'll share my slides, Maria.
Oh, sure. Okay.
Okay. So good evening. Well, it's evening in my country right now. Good day, everyone. And thank you to the ISNTD for inviting me to share my experiences about yaws in the Philippines. So let me start with this quote. There is nothing new except what has been forgotten. And today, I'm going to tell you a story about what has been forgotten and found anew. Hello, I'm Dr. Belen Dofitas, a dermatologist, and I'm going to share with you my research and my experiences about yaws in the Philippines and how I found it, even though it is a forgotten and neglected tropical disease in my country. First of all, I'd like to disclose that I was the principal investigator of 2 yaws studies commissioned by the Philippine Department of Health, and currently I'm a technical expert consulted by the Department of Health for yaws and leprosy. And I'd like to thank the Department of Health Philippines for funding these studies, and the Philippine Council for Health Research and Development for sponsoring the studies as well. These studies were implemented by the Philippine Leprosy Mission, which is an NGO. And I have also had support from the Push 1 UPCM Postgraduate Studies Program grant and my thesis advisor, Professor Jan Hendrik Ricardos of Erasmus MC Rotterdam. Of course, I have to thank so many people for the yaws studies, and these are teachers and rural health unit personnel in the southern Philippines. And of course, during the height of the pandemic, the COVID pandemic, I'd like to thank everyone who worked very hard despite the threat of infection from COVID. First, I'd like to give an overview about what yaws is and how I found yaws in the country, plus the lessons learned along the way. I'm a dermatologist, and I have a special interest in leprosy, and that's why I conducted this study commissioned by the Department of Health in the year 1999 to 2000. It was about health-seeking behaviors of persons with leprosy, but I did a community skin survey at the same time in 30 towns across the country. And in one of them, the municipality of Datupiang, Maguindanao in southern Philippines, when I landed there, the local health workers asked me, "Doctora, have you ever seen yaws?" And I said, "No, never seen yaws." And then I just read about them in the medical books. I said, "Well, we have a lot of yaws here." So in that time, year 2000, all I could recall about yaws was it's a non-venereal trypanematosis. And so the local health workers brought a lot of children to me to show me what yaws was. And for example, this 10-year-old boy had thick yellow crusted pruritic or itchy pink papillomatous nodules on the ankles. He also had this moist, soft, pink, volcano-like large papillomas and atrophic scars on the buttocks. So when I first saw yaws, I thought to myself, being a dermatologist, I said, are they secondarily infected insect bites, perhaps? Or maybe furunculosis, like boils? Or is this impetigo or perhaps eczema? But all the locals told me that what I was seeing was bakataw. So that is their local term for yaws. And looking back at this photograph in 1954 in the Philippines during the yaws campaign then, bakataw indeed is found in their posters during the yaws campaign. And it has been there ever since they can recall. So what is yaws? It's basically a tropical, highly infectious disease that affects the skin and bones, and it's passed through skin-to-skin transmission. It's not sexually transmitted. It mainly affects children and in remote, impoverished communities, and the cause is Treponema pallidum pertenue, which is very closely related to the cause of syphilis. And you can diagnose it through the clinical appearance plus blood tests. And yaws is actually one of the neglected tropical diseases earmarked for eradication by the World Health Organization because you only need one dose of azithromycin, oral azithromycin, to clear the infection. So it's potentially eradicable. So how bad is the yaws situation in the world? Actually, at around this time, there are only 15 endemic countries identified. And the Philippines was the 14th country, followed by Liberia. And fairly recently, Malaysia reported one case of yaws in an indigenous, a child from an indigenous people's group. Only India has been certified as free of yaws transmission in 2016. And there are several suspected cases around the world and a lot in the Western Pacific region. But they need a lot of confirmatory tests. 107 countries have no previous history of yaws, but those that were previously endemic but do not report any yaws or do not know what the status of yaws is in their country are 82 countries. yaws in the Philippines was historically widespread during the Spanish and colonial and American colonial period. So for those who do not know about the Philippines, we were under the Spanish rule for around 4 centuries, and under the American period from 1898 up to 1946, around 40 plus years. So even in those times, there were reports of yaws, such as this child in a museum photograph. Now, there was a yaws eradication campaign from the 1950s to the early 1960s, and it was called the WHO UNICEF-assisted trypanematosis control program. Because of the one-dose penicillin injections, the yaws prevalence dropped to 0.4% by 1960. However, it was not totally eradicated. Some cases remained and became forgotten and spread again. In 1973, yaws in the Philippines stopped. After 1973, yaws in the Philippines stopped being a notifiable disease. So that is the reason why it was just out of the radar. Now, by 2012, yaws was declared by the World Health Organization as an eradicable disease, and it only takes one active yaws case to consider an area or a village or even a country endemic for yaws. So by 2013, I again talked to the Department of Health about including yaws among the neglected tropical diseases in our country, but they insisted on a baseline prevalence study. So in 2013, we started working on the protocol, and I was commissioned by the Department of Health to conduct this baseline or prevalence study in known areas or where I saw yaws before. But I only started the study in 2016. It took a lot of time. And our Department of Health wanted to know that, do we need to establish a yaws control or elimination program, either as a vertical or as an integrated program, given the status of infection here in the Philippines? So I will summarize my research methods. In the two studies, they were epidemiological, so I did surveys, but I also did qualitative studies or interviews of selected participants. And there were different sites. For the first study, I focused on the southern Philippines, where I first saw yaws suspects. And in the second study, I focused on the two other island groups of the country where there were no reports of yaws at all. Yeah. So these were more case detection studies in 2019 and 2020. So basically, what do you do when nobody seems to remember what yaws is? Okay. But there is a chance that there are some who have an idea what it is, just like the health workers I met in the year 2000. They were the ones who knew about yaws. So I decided to do some crowdsourcing for any information on yaws, and I did it through electronic surveys of physicians and health workers around the country. Why? Because I basically didn't have the budget for some extensive, case detection or even some large prevalence studies. And I also did some small or focused cross-sectional surveys in public schools, doing skin screenings, or even for those who wanted to be checked up. Plus, I also had serologic test kits with me. Now, those who we found to have confirmed yaws or latent yaws or past yaws, we selected them for in-depth interviews. And after we had discovered or found those who were active or latent, we gave them oral azithromycin as targeted treatment, including their close contacts. So basically, this is how I plan out my study, that we have first a lot of meetings, orientations with the stakeholders in the communities, training of the field team, because they also needed to recognize yaws and know how to screen the community. we had to create information and education materials and translate them into the local languages and add Filipino pictures and have our own recording and reporting system in place. Then, before we could start any surveys in the community, we had to do social preparation, such as public health lectures and school orientations. And after that, the children and the community members were more willing to be checked up. So what did I find out in my exploratory surveys, or what I call the crowdsourcing through the actually used free platform, like Google Forms, and then ask them also, have you ever seen yaws? So it's not, it has to be something that they've seen in the past. So I just wanted to know, has anybody ever seen yaws? And in the first study, there are over 1,000 health personnel invited. Only 3 dermatologists, or 2.3% of the 131 who answered my survey, reported having personally encountered a yaws case or cases in the past. And they were either seen in Manila or in the southern Philippines. And only 15 of them had ever heard about yaws cases in the Philippines, mainly dermatologists. So in the second study, I again repeated this crowdsourcing for information, and almost 4,000 health personnel were invited around the Philippines by emailing them. And I was so happy that we received 2 reports from doctors about yaws suspects, and these were among indigenous peoples. So I had proven that yaws has indeed been forgotten in my country through these surveys. So they're difficult to recognize even by doctors. Even though it's right in front of them, they may not recognize it. So very few government physicians and dermatologists had ever encountered a yaws case in the past, and majority of the respondents had no information about yaws. So I first found yaws in 2017, and this was indeed in the southern Philippines. So all I needed was to find at least one active case of yaws at that time. Is it present or absent? That's all I needed to answer, really, and then try to find a prevalence among the school children. So 5 out of 9 sites that were previously endemic for yaws had really members who had either active, latent, or past yaws. I found 4 confirmed active cases, 8 latent yaws, and 2 past yaws. And only 1 school child that had confirmed yaws out of 2,000 plus that were surveyed. But there were 4 children who had active yaws that were found here. In the second study, I focused on the northern and in the middle part of our country, and we screened children in small remote villages where yaws may likely be hiding. But I found yaws only in 1 of those villages, 5 active cases among indigenous people in Quezon province, but no yaws cases in the middle part of the country during this study. So in summary, out of these 3,000 plus children and adults examined for any skin disease, we found that the clinical seroprevalence actually was quite low. We found around 33 Filipinos affected by yaws during these 2 studies, and 9 active infectious cases and 10 potentially infectious cases, and 1 case of bony disease in a child, but no tertiary cases. But if I look back at all the previous reports about yaws in the country, starting from my experience in year 2000, where I found a total of 118 patients with signs of yaws at that time, up to the survey by the report by Médecins Sans Frontières of treponemal pregnant women with positive treponemal antibodies, and followed by Dr. Shirjan Kalim's serological survey of women and children, finding several of them positive for treponema pallidum. If I add them all up, I could say there were at least 250 yaws suspects and confirmed cases after 1973, which was the last time yaws was officially reported. So yaws today in the Philippines is only found in two major island groups, Luzon and Mindanao. The distribution is spotty, but despite the limited study sites that we had, we were still able to detect yaws, even though it's relatively rare. But all of these are, an underestimation. Why? Because yaws cannot be recognized now easily. It's forgotten. It's not being reported. It's not in our surveillance system. So yaws among Filipinos, I'd like to share some photos with you because this is yaws in brown-skinned individuals. No? And it helps us recognize yaws in our country. So like this 1-year-old with several yaws, lesions clustered all over the body. No? And this is the index case or the first case we encountered in 2017, where I was able to confirm that we do have yaws. It's a very florid case. You see the moist cauliflower and surface, and underneath you see the raspberry-like appearance of the papilloma. And that's why yaws is also known as framboesa or raspberry in French. So even without a serological test, this clinical appearance is certainly yaws. It can also look like papules, and scaly papules and plaques and whitish like this. So it really doesn't look like anything much, maybe like ringworm perhaps. No? Okay. But it's still yaws. And yaws affects the palms and the soles, especially the soles. And we saw a couple of cases. Like here you see a yaw on the sole, and obviously this is a yaw on the sole of the child as well. It can cause bone disease. It also softens the long bones. So like this child in the indigenous people group had the bowing of his forearms a few months after his yaws lesions started. Now, yaws is not merely a physical disease. It's also actually a psychosocial and socio-economic, it has these effects also on those who have yaws. How did I find this out? Through our in-depth interviews. So I interviewed 26 yaws cases, household contacts, and health workers, and found out that because it is not sexually transmitted, but the blood test results are the same as syphilis, those who have yaws and these positive blood tests are thought of to have had syphilis or have syphilis. And so it becomes stigmatizing. Okay? So as a child, yaws could just be like a physical disease, or they have ugly looking skin lesions, it's foul smelling, and so they probably get bullied or they don't go to school. But yaws actually affects all stages of life. Because when they reach the working age, like maybe late teens or in adulthood, and they want to work abroad or overseas, they're being rejected because they have positive blood tests like syphilis. So there's a loss of income and opportunity because they had yaws in childhood or they currently have latent yaws. Okay. So we have to remember that there's a dimension beyond neglected tropical diseases, and this is the psychosocial and economic problems that they bring. So my key points today are yaws is endemic in the southern Philippines and among indigenous people of the Quezon province and the adjacent province where they migrate to. The prevalence of yaws is low in the Philippines, but it's still underestimated due to very limited sampling of epidemiological studies. There's an absence of nationwide active surveillance of yaws, therefore the numbers are low. Two major island groups, Luzon and Mindanao, now have confirmed yaws cases. Yaws may be stigmatizing among Filipinos and have negative socioeconomic effects. Yaws is unknown, unrecognized by the health sector and the public. It's virtually forgotten. Now, how do we find a forgotten disease like yaws? So I sum it up in what I call a two-pronged approach. First, examine historical records of yaws endemic sites, which I did. So scored the Philippine health statistics from the 1950s to the 1970s. And the last report was indeed 1973. Then I targeted high-risk villages for yaws. They're remote, or they have indigenous peoples there, and they're quite impoverished. After that, interview locals as well. No? They may have seen yaws or were really familiar with it, just as how I experienced it the first time in the southern Philippines. They will even teach you how yaws looks like. No? And you can't get that anywhere except in the endemic villages. And you have to show people how yaws looks like. So I prepared these colored images and distributed them, no, to the school children and the community. Have you seen skin lesions like this? And then they were all invited to the skin screening, where we did serologic tests for all those who had suspicious skin or bone lesions. Simultaneously, you could do the crowdsourcing through online surveys of health personnel, like these Google forms which I used. Have you ever seen yaws? At the same time, sending them the yaws fact sheet and the yaws recognition booklet, so they could recognize it. After which I encouraged all of the health personnel to please report any yaws suspects anytime to me. And then that's how we'll be able to focus our search in those areas without wasting a lot of money going around the country. So right now, only leprosy and lymphatic filariasis actually been programs in my country. And recently, yaws became one of the 13 neglected diseases for elimination from 2024 to 2030. So because of the two yaws studies that were conducted. So from research to policy and action, I think that's the important part of my experience. So because of these evidence that were generated from studies, the Department of Health was convinced to include yaws and to reinstitute it in the surveillance system of our country again. So I've been included in the planning workshops. And of course, the WHO Geneva has been very supportive. They donated azithromycin and test kits. I was able to give these supplies to the Aita village where yaws is endemic. And then we plan to do the campaign in the adjacent village where there are still Aitas with yaws. I've also sent these supplies to southern Philippines, the province of Maguindanao, where they plan to do yaws campaigns before December this year. Also explored partnerships with agencies with common interests like the UNICEF, because they deal a lot with children and also have resources. Now, you may think that the numbers of yaws cases in the Philippines is very low. It's just a small problem. But we have to think that it's because yaws is very underreported in my country. It's hidden, unrecognized, and neglected. But we have to remember it only takes one active yaws case to spread this disease rapidly. So we have to act now while there are few endemic cases, apparently. Now, what a journey indeed it has been for me. It's actually been 23 years in the making, from rediscovery to health policy. I'll end with this quote. Whenever we give up, leave behind, and forget too much, there's always the danger that the things we have neglected will return with added force. By Carl Jung. Thank you very much.
Belen, what can I say? Thank you so much for this incredible presentation, but also your work along the last 23 years. And I think that's really what stands out from your presentation, is that neglected diseases need advocates, and advocates that are there over time and able to kind of take this journey right from the neglect or the forgotten disease, as you so well said, all the way to the policy. That's really astounding. And very interesting that you also highlighted the fact, you're yourself a very established and respected dermatologist, but there were gaps in your knowledge and your colleagues' knowledge. And that's also very important to remember, that even for global health professionals, people who have been in the field for a long time, these diseases can still remain a puzzle. So it's also the first time Young's been quoted in a tropical disease meeting, I think. So all around, a really enlightening presentation. Thank you so much.
Thank you so much as well for allowing me to share my experiences, which actually I hope all those 82 countries who are previously endemic with yaws but do not know their status of yaws, I hope they'll pick up these tips and start searching for yaws as well, so that yaws will really be eradicated worldwide.
Yeah. And likewise, the one case that can really lead to a resurgence, that's also a very important point to remember. So that's been really enlightening. And I'm sure there'll be more questions from our audience for our discussion in a few minutes. Actually, Mbutidem Akpan has already said, nice presentation. I completely agree. And thank you for joining us. A quick hello to our audience tuning in from Nigeria, Marta Ribas, working on Noma and connecting from Spain. Hello, Collins on DT from Kisumu in Kenya. Patricia Akintan, welcome, also from Nigeria. So to everyone who's on the call, big hello from us. Thank you for joining us. And I think this will be a great time to move to our second speaker, Belen. Thank you for your time. And I'd like to welcome, please, our second speaker, who will also talk to us about a very forgotten disease, also a disease that healthcare professionals, even in primary healthcare, may not have heard of, may not have encountered before, and that is the disease Noma, very neglected, but also terrifying in terms of the speed at which it can progress, and also the burden, the depth of burden that it can impose on those who are affected by it. So without any further delay, I'd like to hand over to Dr. Adeniyi Semiyu Adetunji. Dr. Adeniyi, you're a surgeon and you're also working enormously with the Noma Children's Hospital in Sokoto. So Dr. Adeniyi, if you can hear me, and if you're still connected on the call, I would love to start your slides and hear a lot more about the search for Noma cases in the community in the Sokoto district.
Okay, we are going to look briefly at the search for Noma cases in the community. Let's go to the second slide. Yes, we'll look at the search using the outlines as above. Look at the introduction, the requirements. What does it take to enter the community? Active case finding, and then we look for suspected Noma, and then how do we communicate with the patient, and what do we need to make the patient comfortable? So we'll look at that too. We look at the problem that we'll face, and finally, how do we manage them when they come to the hospital? And then we'll conclude. Let's go to the next slide. Yes. Now, if you look at Noma, Noma can be said to be the face of poverty. Nobody would like to be, to be attached or used as a symbol, status symbol of poverty. So Noma is an orofacial gangrene which mainly occurs in malnourished children, debilitated by disease and living in developing world. The mortality rate of Noma is high, and the survivor harbor or live with such facial disfigurement that made them to be rejected by society and family life. And when you look at the mortality rate, usually is about 90%. And we can also see that Noma has a necrotizing ulcerative stomatitis, gangrenous or cancrum oris, which is a rapidly progressive and often fatal infection of the mouth and the face. Within 1 week, the child is debilitated. Let's go to the next slide, please. Now, what are the risk factors which usually make children to have Noma? You can see those risk factors there. These include malnutrition, concurrent diseases. Those are the 3 M's and the other: malaria, measles, malnutrition, HIV, TB, typhus. We have poorer hygiene, which is well documented as a risk factor. What about lack of breastfeeding in the first 6 months of life? Proximity to livestock, not only to food, but to water sources. Then delayed access to medical care when needed. So these risk factors are always a pointer to the presence of Noma in any community. Let's go to the next slide, please. Now, for you to search for Noma in the community, there are some things that are necessary. Necessary in the fact that you cannot just enter a community without having all these necessities. The first thing is you need to have an outreach unit. Part of that outreach unit, you will need to have a scouting unit, which will always be an advancing group that will always go into a community to prepare the place for the visit of the outreach unit. And you also need, in that outreach unit, dedicated people who are interested in those people that are suffering from Noma. Not only that, you need good record keeping, because you will need to take down data. And you also need to have record of location where you can get all these people whenever it is necessary. Then you need audiovisual materials. These are the things you must arm yourself with when you are going to look for Noma. Last of it is you need to have adequate knowledge of the terrain. The geography you must know, because you might need to move anytime whenever you hear that there is a suspected Noma case in the community. Let's move to the next slide, please. Now, before you can get a Noma case in any community, you must also create realizable objectives for yourself, knowing the fact that Noma in its entirety is a neglected disease, which nobody would like to associate with. And coupled with the fact that it's related to poverty. So the first realizable objective when you are going to look for Noma in the community is that you must create awareness about the Noma disease via pictures, posters, radio jingles, drama, and also there is television available, which you may not get in some of those communities. You can also use that to create awareness. And also, you must focus that awareness on early detection. Once these patients are detected having Noma, treatment can be given without wasting time, so that the sequelae will not develop, and thereby reducing the resources that has to be wasted if it is discovered late. And then talk of prevention and the referral system. We thank MSF, because MSF has been in forefront. MSF Holland has been in the forefront of realizing these objectives. Let's go to the next slide. Now, when you are looking for a Noma in a community, you have to create a rite of passage for yourself and for the group. And the first thing to do in creating the rite of passage is you must send a scout or a scouting unit to the community. The scout will meet the people, especially the village head or some people who are well known in that community. Usually you go to the community leader and fix a time so that the community leader can gather the whole of the community. Most especially, it may be during the market day. And those market days, you can easily get a lot of people that comes to the market to get some things. And through that, with pictures, posters, and some jingles, people will realize that you have something in mind to do. Now, for the way to enter the community, the best way is through health promotion. First thing is that we know that the risk factor, one of the risk factors in the Noma disease is oral hygiene. So you use that as an opportunity to discuss the oral hygiene with the people in the community. And through that, you introduce them to Noma with the picture of patient who had the problem at early stage and telling them the signs and symptoms of those of the Noma condition when it's just starting, and teaching them that simple oral hygiene can prevent patients from having Noma. And the next way also is through nutritional education. Most of the Noma patients usually have they are malnourished, and this malnutrition itself can be prevented. I mean, because what most of these villagers has is enough to provide adequate nutrition. So we use nutritional education also to enter into the community. Through that, we'll be able to get attention of women and the community leaders, and thereby drawing attention to Noma. And then hand washing. You know, most of our communities, they keep animals, and animals live nearby. They drink from the same thing, and people also drink from the same source of water. And we have to teach them through hand washing how they can prevent Noma. Now, when you talk of location, I mentioned the first contact is usually the village head or some other prominent people. So the location may be in the marketplace, town square, or in the house of the community leader, which we call Gidan Seriki, or somebody that is rich in that community. So people can meet there, or through religious leader. And those religious leaders usually facilitate the entry easily into the community. And during the discussion, then some people will tell you that there are patients or there are children with social features which they seem to be related to Noma. So through that one will lead us to suspected cases which we can find in the community. And during the health promotion, you discover that some people will tell you that they have seen somebody with these same features that all normal patients used to have. And through that, we may get active case. And so entry into the community is always facilitated through all these means. But the best way is through health promotion and also through the leaders in the community. And by that, we are able to get Noma patients. Let's move to the next slide, please. Now, when you have gotten this patient, most of these patients will not want to follow you. And the reason is you need to communicate with those patients. Not only the patient and their relatives. There are questions that will be bothering these patients. One of those questions is about transportation. How will they get to the city? Who will take care of them? So usually, like as I've said, MSF and the hospital management usually provides means of transportation for this patient. Usually, MSF will pick the patient up and bring the patient to the hospital. So we explain to the patient that transportation is not a problem. And then the patient will ask you, when you get to the city, how will he be admitted? Admission is also free. And we will also reassure the patient that while the patient is on admission, feeding and the provision of basic materials are also free of charge. Then the next issue is about the consent for surgery. So usually you have the caregivers. The caregivers may be a relative or may be the parent. And these caregivers, they are the ones that will give the consent for surgery. So through this, you'll be able to tell patient also that surgery itself is free. They don't need to be worried about it. And by that, patient is reassured, and then the patient can decide to follow us to the hospital. Then the next slide, please. Now, what are the problems when we are sourcing and we are looking for normal patients in the community? The first problem that we always encounter is the knowledge gap. Firstly, some of these patients believe that that is their destiny. They were born to live with this condition. So some feel that it is not necessary for us to do anything for them to take care of them, that it is better they continue to live their life like that. But by the time we sit them down and I explain everything to them that this is not the purpose of they being alive. They have a better purpose by being well fitted into the society. Then, with all this explanation and some other things, patients will always calm down and they will follow us, including the relatives. Because without explaining to them, most of them believe that when you get to big cities, you are going to have a lot of problems. What about transportation in the city? And also, but since we are the one that will pick them up and bring them to the hospital, it usually facilitates their presence in the hospital. And it also encourages acute normal cases to come to the hospital since the treatment is free. And the next problem that we face when we are looking for normal patient is finance. The patient will also ask you who will take care of him, who will provide all those things that is needed to make them get well when they get there. So we always reassure them. We want to also say big thanks to MSF. MSF has been in the forefront of also taking care of these patients financially by means of transportation, both to the hospital and after leaving the hospital. So usually by the time the patient is coming, he's happy that he's going to get something to take care of his coming. And then the other problem we tend to face is the problem of security. Now, insecurity is making it so difficult to go and locate this patient. Most of these normal patients are always hidden. Nobody will also like to relate with them in the community. And then to get them now because of security challenges around the nation is very difficult. So, and that will lead to the next point. We are now using the remote management method through focal persons. People that we already know in those local governments, we use them as focal persons, or patient that has been operated in those regions. We use them as a point of contact so that whenever they see suspected normal cases, they will know how to send them to the hospital. And those focal persons that are there who are working in the hospital, we also make sure they have a means of communicating with the hospital whenever there is a case of a normal patient. Then the other problem is transportation, as I've mentioned before. Coming to big city is an issue. And as I have said, MSF with their outreach unit, which is helping Noma Children Hospital, are really working wonderfully in that area by providing means of transportation for the patient. And then when patients also, they are leaving the hospital, they also get transportation money. And that has been helping. Otherwise, it will be difficult getting them to the hospital. And then I talk about the problem of geography, of the location. The terrain is difficult. There are some areas where you don't have good road to get into the community. So you need somebody that knows the terrain. This is one of the other big problems. And so there are other little problems which we encounter is the problem of language. You must also be well versed in the indigenous language. Otherwise, you cannot win the patient confidence. You cannot win the community confidence. But when you can speak the language, you can help the patient come to the hospital. These are some of the few problems. There are other ones, but these are the ones which we are tackling right now. The next slide, please. Now, in conclusion, Noma is said to be the face of poverty. No government would like to be, to associate with Noma. And this is what is making Noma a neglected disease. It is always there, but it can be prevented. What we always emphasize whenever we go to the community is that this Noma is not contagious. This same Noma cannot be transmitted from one person to the other. It is not congenital. That is, you are not born with it. It is something that is treatable. It is something that you can still get rehabilitated for. And at the end of it, you can still fit into the society. But as long as Noma is hidden and the community doesn't want to talk about it and the government doesn't want to, associate with it, it's still going to be one of those scourges that will continue to decimate humans. But if we have good community participation with adequate knowledge, this will help in prevention of this scourge in the society. Noma is there. As long as there is poverty, Noma will always be a human scourge. Thank you.
Thank you very much, Dr. Adeniyi. I almost feel quite emotional after your presentation, if I'm honest. Noma is, as some have said, once you see it, you can never forget it. And I think it's just something that really stays very close to your heart. Once you've heard about it, work in it, are involved in it. And I think you've conveyed that really well in your presentation. Thank you so much. What's also admirable is how throughout almost every slide you were placing the Noma survivor or the Noma patient or the community really at the center of everything that is being done in the Sokoto area and further afield to really detect, find, support, encourage anyone who's affected by Noma to seek treatment. So we've learned a lot from that presentation. Thank you so much. And I'm sure there will be lots of questions for you coming up in our discussion. Dr. Belen Dofitas, who was presenting to us before, has also added a very interesting comment here saying, totally agree with Dr. Adeniyi. The peace and order problem of the communities have hindered the detection and treatment of NTDs like yaws and Noma, even up to this day, and that's really topical. Conflict getting in the way of healthcare is a real tragedy, and so thank you also for bringing up that point. And so before we turn to our discussion and to our lovely audience, please don't hesitate to put any questions or comments or feedback in the chat. I'm going to hand over to our third speaker, Dr. Tine Huyse, who's also a champion for an approach and a method and working in an amazing team. So we really have three giants on the call today. I'm very humbled and honored. But I'll hand over to you, Tine, to share with us your amazing approach to detecting schistosomiasis and really engaging the community in a very original way for that purpose. So thank you so much, and over to you.
Thank you very much for this nice introduction, Marianne, and I'm happy to be here. So here in the slide on the background, you see a picture of Lake Albert from the Ugandan side, and estimates suggest that the prevalence of bilharzia can reach up to 80% or more in these areas. But we actually lack recent figures on the prevalence, even though it's a highly endemic area. So how come? Why is this? And it is because you need to cross the Great Rift Valley, which you see here. So you need to have a car drive of several hours, and after this, a challenging motorcycle drive before you can reach these areas. So you can imagine why it's impossible for government officials from the Vector Control Division to do regular surveys. So in order to meet this problem or this data gap in remote areas, we came up with the ATRAP Project, which started in 2019, and it stands for Action Towards Reducing Aquatic Snail-borne Parasitic Diseases. And here we wanted to explore the possibilities of using citizen science to really as a solution to this knowledge gap. Now, before explaining what citizen science is, what data do we need? So I show you here the life cycle of bilharzia. And if we want to know the possible transmission sites where bilharzia can occur, we need to know where the snails are, because snails are a crucial part of the parasite life cycle. The parasite is developing in the snail. And so it means without the snail, there is no disease. But next to that, we also need risky water practices, because these will determine infection, exposure, but also contamination of those sites. So if you want to know the potential transmission sites for schistosomiasis, you will need data on the snail presence and data on risky water practices. And these are the types of data that we want to collect through this approach of citizen science. Now, what is citizen science? It's actually a fancy term for practices that have been ongoing already since a long time, but maybe not exactly in that format, but it's actually the involvement of citizens in the scientific process. And in this case, in Uganda, we worked with 25 citizens that were involved in weekly snail monitoring of 76 sites in this area surrounding Lake Albert. And for doing so, we equipped them, first of all, with protective gear, like gloves, boots, then a snail scope, smartphone, and then at the start, which was a 2-day training, they were shown how to identify the different snail species up to the genus level. And then with this information and equipment, they could go out for the weekly sampling, which is half an hour sampling, scooping. Then they identify the snails to genus level, take a picture, count them, and they will upload all this data with their smartphone using the Kobo Toolbox application. And then all this data is validated by a PhD student from ATRAP. Now, also just to add, these citizens were actually selected together with the leaders from all the villages, because they need to be well supported and accepted by the community. So the selection process is also very important, but I can talk about that later if needed. So what are the benefits of involving people in science or in monitoring approaches? Of course, first and foremost is this extensive data collection. So we could select thousands of snails over more than 2 years, which resulted in more than 6,400 reports, reporting on more than 82,000 snail specimens. Of course, data quality is very important, so we came up with a very stringent validation protocol, which included visual validation, automatic validation, but we also looked at observation bias. Now, quickly zoom into this. So what did we do? So the same sites that were visited by the citizen scientists on a weekly basis were visited by an expert on a monthly basis. And this expert was also looking at the presence and absence of the same snail groups, and also at the abundance. So we could compare the data of the citizen scientist and the expert. And if we look at the abundance data over time, we can see the solid line is actually the data collected by the expert, and the dashed line, the data by the citizen scientists. So you could see there's the same relative trend in snail abundance, reflecting the seasonality of transmission, which is well known. But the citizen scientists each time report lower numbers. This is somehow compensated by the fact that they are sampling on a weekly basis. So if you accumulate all those reports, the figures were much more alike. And also, if you look at the presence and absence only, there was about 76 agreement for the snail species Biomphilaria and 86 for the radix species. Now, this is the data from the citizen scientists all pooled together, showing that also upland, we have a high abundance of the Biomphilaria snail, which is transmitting bilharzia. And also which was actually not known until now, especially not these high numbers. And also what we see is that the number of water-related activities, which the citizens were also recording, each time when they went sampling, they were recording which kind of risky water practices people were engaging in. And also upland, we see there are a lot of risky water practices ongoing. So another benefit is the cost efficiency. So we compared the costs for the expert, in this case, the PhD student. The salary would be much higher if we are thinking of government officials, of course. But even with this comparison, we see that it's 8 times cheaper to work with the citizen science concept. And we also, the costs for the citizen science network to be operational is also regular training. So not only at the start, but also during the 2 years, we had some refresher trainings. And also for this community building, this is really important. Now, it is not only about data collection and cost efficiency, but it's citizen science can be much more than that. And it can really lead to community empowerment and engagement of the communities. So these same citizen scientists were also involved and trained for outreach. And together with the communities, they really created these bottom-up awareness campaigns. They chose the tools to communicate, for example, flyers, signposts. They also chose the method, so door-to-door visits were chosen, even a football match was chosen, drama and songs were chosen to really inform the communities about the risks and also about the prevention, how you can protect yourself against the disease. And more than 25,000 people could be reached during this 1-week intervention campaign. Then community empowerment also means knowledge. Knowledge is power. And so what we did after the intervention and at the baseline, at the start of the study, we did a CAP survey to look at knowledge, attitudes and perspectives of the communities towards the disease. And so at the end, after the intervention, 91% as opposed to 73% think that it's important to avoid contact with contaminated water. And we also saw that these intervention campaigns incited local actions by the local leaders and also the creation of new bylaws. For example, they put signposts, which you can see here on the picture, next to the putative transmission sites to really advocate against open defecation, which is fueling the transmission cycle of the disease. But they also created water committees. They looked at which boreholes are still working, which not, and so on. Then in the next phase, we will also work on the mobile app because this will allow us to really provide feedback in real time. So now, after validation by a PhD student, this student would contact the citizen scientist by WhatsApp, like, okay, you made a mistake here, or we see that you didn't go sampling, whatever. So there's always a delay of a couple of months, especially also for the snail identification. We now have a tool with machine learning that can check in real time the identification of the different species up to genus level. And we're working to have this web application into a mobile app application. And this would really allow upscaling and to have the citizen scientists become independent of the physical presence of the team. This is also very important if you're working in remote areas. So we think that citizen science has a great potential for disease control in remote and highly endemic areas because of the extensive amount of data that can be collected both through time and through space. And the data was of acceptable accuracy to know where the snails occur and with which abundance. It's also significantly cheaper than having expert-led surveys. And it has been shown that involving citizens in the scientific research is really empowering communities, is increasing the knowledge of the communities. They bring their children and their family when they're sampling snails, so it's spreading the news about the importance of the snails, and also involving them in these awareness campaigns really increases the resilience and the sustainability of the interventions. So I would like to thank the entire team, because of course this is all depending on the great teamwork. It's the University of Mbarara in Uganda. We also have a network in Congo with working with Université de Kinshasa, INRB, University of Leuven and Antwerp, and it's sponsored by the Belgian Directorate for Development Cooperation. And last but not least, of course, a big thank you to all the citizen scientists, because without their help, this would not be possible. Thank you for your attention.
Thank you so very much, Tina. Another incredible presentation, an amazing project. Lots of champions there, not just for your solution, but really of the entire disease, and also of empowering, as you said, the communities that are affected. So all three speakers, honestly, a huge thank you, not just for what you've shared with us, but really just your efforts along all these years to really make an impact and a change on some very difficult diseases to tackle in really challenging situations. So thank you. I'd like to take this opportunity to ask Belen, Dr. Adeniyi, if you don't mind to put your cameras back on. I'm sure there will be a few questions coming up from the audience, but also from our part, it'd be just really lovely to have a short discussion after all this food for thought that you have given us. Dr. Adeniyi, there's a way. Oh yeah, you got that. Thank you. And I just wanted to pick up on a few things that had come up in the chat, particularly Belen, you were asking, may we see before and after photos of the surgery done on Noma patients? Really complicated surgery, drawing on plastic surgery, trauma, cancer. It's, I think, Dr. Adeniyi, you were being very modest there, but the work you do is just simply amazing, and also really thinking about the mental health and just the support of the individuals in question as well. But just to address that point, perhaps there will be an exchange of photos, but also I have put in the chat a link to 2 short films based on a much longer feature, an hour long, and really showing the journey of the Noma survivors. And those are 2 films by Claire Jantet and Fabrice Caturini from the French production company ISNTD. They're on YouTube, and particularly the slightly longer one, the first link I posted, really, you know, an image speaks 1,000 words, shows very vividly some of the transformations and what's involved there. But moving on a bit more broadly from all this, one thing that really strikes the audience when we hear your amazing presentations is just really how you perhaps unwittingly become advocates for this disease through the work that you're doing, whether it's just in terms of epidemiology or case detection. And is this a role that, would you agree, do you feel that these diseases are now really close to your hearts? Do you feel like you're not just there to fill some gaps, but that you're really advocates for the diseases in your own countries or regions or speciality? And perhaps I'll go around the speakers in order of presentation. So Belen, you first.
Well, as a researcher, actually, I feel it's my responsibility to make sure that, the findings, the important findings of research are translated into policy and action. Or else it's such a waste of resources to just do research and then nothing is not being used. So I have actually experienced this myself as a researcher. You know? You're commissioned to do study, you submit your report, to the government, and then what will they do with your report? It's just like a report. So I think it's a researcher also becomes a change maker. You're not just a researcher. You have to make changes because you have the knowledge and the expertise to do it. Who else? So the other role we have to play is we have to guide the government agencies and of course the public sector as to what is the way forward. I mean, you are like the expert in your country, so it's your responsibility, to advocate. And I always say that people who have neglected tropical diseases, and even those who are not yet labeled as neglected tropical diseases, they live in remote villages and they are not seen. It's as if they don't count. So it's our responsibility as, health workers, as researchers, to be their voice. So we have to speak on their behalf, and to make them heard. So like the problem of yaws and the stigma attached to it, because they were being thought as, they were being treated like syphilis patients. So stigmatizing, and they couldn't get work because of it. So those patients actually talked to me and said, please cure us, but it's not treatable. So we have to educate them and reassure them, that no, you did not have a sexually transmitted infection, and they feel relieved. But we also have to convince the public, social awareness, so that the stigma will be reduced. So that's our responsibility. I feel basically as a researcher, we're not just doing research. We have to make sure, this things change for the better.
So it's a big responsibility on that continuum of the journey between the case detection all the way to the policy and beyond. Dr. Adeniyi, how do you feel about your role? I'm sorry, I think you're still on mute.
Can you hear me?
Yes.
Beautiful. Now, basically, when you look at thought of people about surgery, they believe that surgery is just to cut and to patch up the patient. It's not that. And when you look at a normal patient, you discover that averagely, most of them, they are not the person they're supposed to be. And not only that, when you see them in the clinic as a child, see them withdrawn, they have this usual appearance, depressed as a child. And not only that, you also see that when they are adults, they tend to hide themselves. So they are voiceless. Not only that, the society does not care for them. They have to be hidden somewhere. Some of them either doing many a job, which an average person will never agree to do. So, in a sense, poverty, which is the harbinger of Noma, is always in every country, especially the developing countries, which we can say they are very poor. Some of them are really not poor, but lack of awareness, knowledge, and some other things. So, averagely, when you see a Noma patient, you also will feel touched because they are like you. And by the time you do a little thing for them, they become more happier and they feel easily integrated into the society. And not only that, you see, Noma disease itself is an opportunity for research. And not only for research, to also help government to formulate policies. You discover that the so-called government, they live in the cities in most of the countries all over the world. But the so-called populace, those ones that elect them, they are there in the bush. And most of them, they don't have access to what it takes to have a normal living standard. Mm-hmm. So I, as a person, feel that working with normal patients is an opportunity to also be an advocate for them. That is from my own angle. Then in addition, not only as a surgeon, because you discover that normal surgery is costly. It's not a surgery that one specialist will just wake up and do. Most of the specialists has to work together with concerted effort to make one normal patient fit into the society. So it's an opportunity for research. It's an opportunity for collaboration at all medical levels, either both surgical and the medical aspect of it. And it's also an opportunity for research to improve the situation of the community. And you also see that it's another opportunity to promote the health of people at the basic level. You discover that people don't need much to live well. But averagely, they have all that it takes to live in the correct standard of life. But because of lack of knowledge and also the inability to access the health care facility on time, and these are the reasons basically that push them to have Noma. So it's an opportunity for somebody like me to work in an environment like that. Have you ever seen somebody being happy? It's more than money. When somebody, becomes better, fit into the society, and can speak and his voice can be heard, he becomes more responsible. And so I believe that is an opportunity for everything to make a human being human when you work with normal patients.
This is huge. So from just efforts for case detection, you've taken us through a huge journey, and this can really have an amazing impact in terms of someone's healthcare, in terms, in fact, of someone's entire life. So this is really, it's everything. Thank you. And Tina, how about yourself? Your work with engaging communities, and how big of an agent of change are you?
Well, I think working with communities make you feel more responsible as a researcher to do socially relevant research. So I actually stepped away a bit more from my fundamental research, which was a lot about genomics, and to really now listen also to the communities of what they think that is important to change in order to protect them better against bilharzia. So in the next phase, so we really talked with the communities, with NGOs, with local leaders, and also government officials, and we adapted our application of our project goals really towards their needs and to look for sustainable solutions. So it did change the way I worked as a researcher, and I think also the way what you do with your results. So rather than only publishing it in scientific journals, we now take the data and go back to the communities. We communicate about what was found in their own communities. And also, like said by Belen, you have to become an advocate and also talk higher up and make the link between the citizens and then the policymakers, bring them together to have these interactions and co-design better preventive measures. So we also developed a policy brief, which was the first time for me, at least. It's a completely different way of writing and communicating, but it's very important to do so. So yes, it does change the way you work, I think, as a scientist, once you know what the consequences are for the disease, for the communities, and how they perceive it. So yeah, that's my take.
Thank you for sharing your quite personal experiences. Tina, there were a few quite specific questions about the app and also the snails, and perhaps as we are kind of coming towards the end of our session, I know you might have to disconnect a few minutes early, but perhaps Anatole, and also we had questions from Boortsedemakpan. If you want to get in touch directly with Tina, then there could be an opportunity for much more detail into how these projects and citizen science approaches were rolled out. But just since we've only got a few minutes left on our call, the one thing I might want to ask you, given your huge amount of experience, your very personal involvement in the diseases that you are trying to understand better and really advocate for, what would you like to see more of in terms of either resources or involvement? How can the global health or the NTD community, in your view, really support and help the work that you've been doing over many, many years? And perhaps just in case you do have to go, Tina, then I'll start with you and go in reverse order of presentations.
Yeah, thank you for this. I will disappear in 5 minutes indeed. But what I think is very important, and you're actually already doing this, but it's really the connecting the people with researchers, but also with local NGOs or policymakers to really develop this integrative approach and learning from each other and increasing the awareness, because I think we can learn from each other, also from other diseases, and you need this inspiration coming in. So I think creating these bigger online networks is a very good start. And I think, yeah, in our case, we still have lots of problems with supply chains like the drug. To get the drug to those remote places is really something we hear a lot when we enter those communities. Where are the drugs? And countries are dependent on international donors. So that's a very inconvenient or a problematic dependence. So this is still something that I think should need to be tackled. I mean, that's also the reason why we focus on prevention, breaking the transmission cycle, but still we need the supply of these drugs really there in the very remote areas. So there, I think, again, increasing the network amongst the different people in the supply chain is very important.
So similar bottlenecks to case detection that then again re-emerge when it comes to the treatment side of things.
Yeah.
Thank you, Tina. Dr. Adeniyi, what would you like to see more of?
Well, I would like to see more of emphasis being placed on early detection, diagnosis, treatment, and prevention. Because the sequelae of Noma is something that is always there, no matter how many surgeries the patient has had in his life, in his entire lifetime. So the best thing is prevention. Thank you.
Absolutely. Particularly given the speed at which Noma progresses, the prevention is everything. And lots of opportunities for support from many different sectors, from oral health to WASH to nutrition. And so, yeah, hopefully this will improve soon. Belen, over to you.
Yes. Well, I'd like to emphasize that we should actually really be giving community skin health more importance. It will benefit not only yaws or skin neglected tropical disease, but even Noma. Because when people value their skin health, they will seek health earlier. Okay, they will not delay that much because they know the skin is important, their mouth is important, and they can actually reach out and have help from the health facility. And you don't need to have a dermatologist there or a specialist, on site. We can already use telemedicine, to refer patients to reach out for help, right? So let's use technology. So community skin health approach is what I've been using, for skin NTDs detection here. And other cross-cutting issues, we can also have to emphasize we're not just focusing on one disease at a time. For example, when we screen for Noma or for yaws or for schisto, we also have to look out for other significant diseases in the community that need attention. So let's not be, very tunnel vision with one disease. It's important, yes, but there are other also important problems we can detect in one go. Integrated approach, community skin health is what I'm advocating. And of course, again, prevention, really, and early detection and treatment is the best. WASH will take care of a lot of problems too.
Definitely. Well, Belen, Dr. Adeniyi, Tina, it's been such a pleasure having you today. You were coming from very different perspectives, but I feel like a lot of the messages were very much shared and shared lessons. We've learned so much. We've also really got a window into your very personal involvement in the diseases, from case detection all the way to building much wider networks and building support for these neglected diseases. So thank you so much for your time today. We've really learned a lot. There will be a recording of this session available. It's on our YouTube channel or our website, and also some of the questions around the Citizen Science Project in Schisto have been answered in the chat. So if you did want to go over those replies, they are there. I just also want to thank everyone who tuned in today, who joined us for this amazing session. It's always a pleasure to cross paths, even though it's online, even though it's on this platform. And we look forward to keeping in touch, keeping an eye on all your fantastic projects. And again, a very big thank you for joining us today to everyone on this call. It was really an enlightening session. Lovely to meet everyone.
Thank you.
Thank you very much for this chance. Nice meeting you all.
Yes.
Thank you. You're welcome.
Thank you all. And we will meet again next week for our next ISNTD Connect. And until then, all the best from us here.
Thank you very much.
Thank you.
And good luck to all of you. Nice to meet you. Bye-bye.
Bye.
Bye.
Bye.